Greetings. I'm Bruce Oviagale, the president of the Society for Equity Neuroscience. I'm honored to welcome all of you to another State of the Science lecture. We are honored to have Professor Charles Ellis as our State of the Science speaker for this month. Dr. Charles Ellis Jr. is professor and chairman of the Department of Speech, Language, and Hearing Sciences at the University of Florida. He is a licensed and certified speech language pathologist who received his PhD degree from the University of Florida. Dr. Ellis's academic emphasis is on adult neurogenic disorders, and he also teaches courses related to aphasia and cognitive disorders. His research is designed to understand outcomes associated with adult neurological-based disorders and factors that contribute to the lack of equity in service provision and outcome disparities that exist among African Americans and other underrepresented minority groups. Dr. Ellis has authored over 180 peer-reviewed journals, publications, written 6 book chapters, and delivered over 200 presentations related to neurological disorders and health disparities, as well as minority health issues. Dr. Ellis, for all his great work, was awarded the American Speech Language Hearing Association Certificate of Recognition for Special Contribution in Multicultural Affairs in 2011, and in 2014, he received the Fellowship of the American Speech Language Hearing Association. Today's State of the Science lecture is entitled Facilitating Equity in Post-Stroke Rehabilitation Outcomes. Look back before looking forward. Over to you, Charles. Thank you.
All right, Dr. Ogle, thank you so much for having me, and thank you for everyone on this call. I am hoping that it will just add to the great work that's already been done here within this group. And I'm going to approach it a little bit different. I am not a physician. I am a speech language pathologist, and I've spent my 30-year career even working clinically with adult neurological disorders, primarily stroke and traumatic brain injury. And in the past, I would say 10 to 15 years, really tried to understand issues related to rehab outcomes, specifically to stroke. And so I'm going to share a little bit of the work that we're doing here, and then really try to connect it to areas that I think that it's disconnected. That I'm not sure that in trying to understand rehab outcomes, I think the rehab disciplines are far behind medicine and nursing for a number of different reasons. But there is some fundamental information that's been generated that I think could help advance the things that we are thinking about. But it's going to require kind of a reorganization and rethought on how we offer rehab, how we measure the outcomes, and other issues related to equity. So here are my disclosures. Just briefly, I'm going to talk through the lens of a person who thinks about communication disorders, but you'll probably see that I'll dance back and forth between communication disorders and rehab outcomes in general, because I think they're pretty much aligned in the type of information that exists in the current literature. I'm going to talk briefly about the social determinants in the rehab disciplines. There's a lot of traction there, but I'm also going to get us to think beyond that process that we've moved into of thinking about social determinants in the last 5 to 7 years, to think about the broader sequence of events that happen that generate these outcomes. I think it's awesome that in the rehab disciplines that we have a better understanding of the social determinants, but I also think that some of the modeling that's happening and some of the measuring, this one point in time, we're drawing some conclusions that need to get us to look back. And when I say look back, I'm going to try to clarify that it's a little bit different than looking upstream, which I think that's part of what I'm going to propose today. But there's also, I think, another lens that we need to think. So I kind of start and end with a thought, and Einstein said we can't solve our problems with the same low of thinking that created them. And unfortunately, in the rehab disciplines, I think we've kind of been in the same place, particularly in aphasia research. And that's kind of where I hang my hat. All of you would know aphasia is a communication disorder that happens after stroke, and it can be very debilitating for people with the condition. And the way that I try to explain it to families is it's slightly different than physical disability because most ADA laws and accommodations are designed for people with physical disability. However, when a person has communication issues, there's not really much in society that helps them to adapt or adjust and to learn to be independent in a very complex world that is now becoming very tech heavy. So in addition to having these language issues for reading, writing, verbal expression, now these same kind of deficits are also impacting their ability to engage in society that's moving into a digital world. So, in the study of aphasia over the last decade, and we've had to push very hard to even get our professions to accept that this is true. I wrote a paper in 2009 that simply asked, does race ethnicity matter? And it took a year and a half to publish that. There was a lot of pushback on that we shouldn't even be thinking about race. People are people are people. And I'll be honest, I almost gave up on the paper, but with some mentoring and encouragement, it is now a paper that a lot of other people have accepted, and they're kind of hanging their hat on that. Yeah, we've got to think about race, we've got to think about sex and gender, we've got to think about all these variables. But even after publishing 20 straight years, there are still reviewers that come back and say, "Well, we don't want that. Take that out of your tables. We don't care because people are people." And I would argue that people are not, that they're complex and there's a lot of things that we have to think about. So in the aphasia literature, the outcomes differ by race, ethnicity. So people who have strokes and have aphasia, Black people and Hispanic people tend to have worse outcomes. There's sex and gender differences. Even though women are more likely to have strokes, men are more likely to have worse aphasia impairment. The literature on age is somewhat mixed, that older adults tend to have worse outcomes in aphasia, but younger adults tend to have more severe strokes that contribute to aphasia. And so it creates kind of this split disparity of young versus old. We know in the stroke literature that socioeconomic status is always going to matter in terms of access. Education matters. And I put probably because the studies, um, exploring education doesn't always yield a disparity. But if we think about education, especially in the US, there are high school graduates that can't read. So if you just plug in a number of 12 or 13, that may not that may not characterize the person's educational level. And in the US, it's really about the quality of the education, and we just have not really measured that. We're starting to move into social support. The broader stroke literature says it absolutely matters, and it's more than just having a spouse. It's really the network of people. So I live in Florida. I have no family in Florida. This is my second time living here. I have a strong network at work and in my church. And so my network is strong, and that would give me somewhat of an advantage in terms of stroke recovery. But one of my concerns is that once we get a concept, we maybe stay there too long and don't necessarily connect all the dots when it comes to stroke and recovery. And this is a paper that was published in 2015, and it's really one that's guided a lot of my work, and it aligns with what we know and understand so about the social determinants. And in this paper, they argue that a lot of the disparity gap after stroke occurs really after people go home. And so that would align beautifully with the social determinants, and that you can see the trajectory of people of color becomes much more dramatic, a much more dramatic decline. And it possibly is related to lack of resources, lack of access to specialized rehab, quality rehab. There are a number of factors that may be in play, but I think it's caused the folks in rehab, and I'm the folks in rehab, so I'm not pointing the finger, to really look at this one point in time and not the entire stroke event. And now that we have such a focus on the social determinants of health and that they probably impact 80% of the outcomes, then we can measure, or we at least we're starting to try to measure the social determinants, but mostly in the post-stroke outcome. So when we're collecting this data, we're not asking people about their social determinants across the lifespan. We're checking boxes on kind of where they are right now. And so if I go in and they measure social determinants, then I'm in great shape. I have great insurance, great employment, highly educated. I go to the doctor every 3 to 6 months. I'm in constant, but that ignores the first 20 years of my life, 18 years of living in poverty and not seeing doctors on a regular basis and having a significant history of heart disease, with both of my grandfathers dying in their 40s, my father dying in his 50s. It ignores all of that. And in many settings, they don't collect all of that information. So it seems that Charles Ellis should have, he should have an advantage, but the advantage quickly goes away when you start to see my family history. So a few years ago, I started to really think about this in terms of the social determinants, and this really made a lot of sense to me. So we started looking at aphasia in a very different way. Um, that in most cases, people who study communication disorders, or really a lot of rehab outcomes, most of the emphasis is on the neurological aspects of it, the stroke size, stroke severity, aphasia severity, and it's not considering all of these other determinants that are in the environment of people with aphasia, how they might be influencing the outcome. So we just decided on a small scale, well, let's just look at naming. Naming is a very common outcome in aphasia, and let's see if we can model naming related issues beyond just where the person had their stroke and the severity of their stroke, but what are all these other factors that might be in play? So I align with a very brilliant economist, and says, Charles, we can model these things by taking this aphasia data that you have, and we can map it onto national data and create these profiles of people with aphasia so that we can explore the issue of social determinants. And so I had a data set of 165 people, and she was able to take MEPS data and create an entirely different simulated sample by mapping people with the socio-demographic characteristics and people who had had a stroke 3 to 1 onto these people with aphasia to create this simulated sample. And here's what we found, which was very different, but right in line with what the economists thought, that higher income and larger family size was associated with these better scores. Age, race, and education were associated with lower scores. And initially, that didn't really make a lot of sense to me. I could understand the higher income because that's tied to um, higher or greater likelihood of having insurance, but the larger family size didn't make a lot of sense to me. And the economist said, no, Charles, it makes perfect sense because in the home setting, the more people who are around, the more stimulation, the more communication that's likely having, and that would drive an outcome. And I thought about my own family. I have 5 sisters that all talk a lot. And when we're together, I am with them, but not necessarily talking with them. But there's a lot of talking, and they'll engage me. And then I thought in this situation, they would not let me sit there quietly as I was recovering. They're going to make me talk. And I think that's kind of the role. So that now this is starting to make a lot more sense of thinking about why family size might matter, and also thinking about why age might matter, why race matters. So that part I understood pretty well because I had spent a lot of time thinking about access and some of the differences and how people of color receive acute care for stroke. They have these longer inpatient stays, but when you go to rehab, if they get to rehab, it's totally reverse. And so the high quality rehab is not happening in acute care, that these longer inpatient stays are just creating this perception that one group is getting more when ultimately more is not more and more is actually less, because it means you're getting longer time in the hospital but less time in rehab to address these types of issues. And of course, education would fall right in line with that. So now I'm starting to get a very different picture of something that I've thought about for a long time and not understood through the lens of social determinants. Of course, upward financial mobility is going to tap you into insurance. It's going to give you a lot of other opportunities, but probably family size, if we believe that this post discharge environment is critically important. Family size would matter. And if you ask any economists, they believe that it matters for almost every outcome of health, because they say the larger the family, the more income, the more resources. All of these are tied together. And unfortunately, when we think about income or socioeconomic, we typically think about just the individual, and it's not really the individual, but it's also the family. So this was another one of those papers that there was quite a bit of pushback because of the simulated sample, but you have to keep pushing against them and find the right editor, and then it will resonate with people. So we didn't want to stop there. So naming is a very simple measure. So why don't we think about these issues that we've learned in this first study, that higher income and family size matters? How could we think about this in terms of overall aphasia impairment? So these scores of their performance, to see if what's driving the fact that people of color very consistently have more severe strokes, and then they also have more severe aphasia. So again, we went right back to the same aphasia um, outcome, but with a totally different set of people with aphasia. So now we're using this aphasia bank that has far more detailed sociodemographic data, and we were able to map that onto to MEPS data as well. And here's what we find, that, and none of these will be a surprise: age, the amount of time post onset, and race, ethnicity is going to matter in language performance. And we've demonstrated that very consistently in other studies. But what we hadn't thought about is that family size probably influences more than just naming, but it also influences overall impairment. So this idea that they're improving in a lot of different language areas beyond just naming. So we found that. And we also found something that was a little odd, that the uninsured are those who had a condition related, those who saw a speech language pathologist, they were associated with higher language performance. So again, I said to my economist friend, that doesn't make sense. How does the uninsured? She says, no, Charles, it absolutely makes sense, because the uninsured generally go to Medicaid, and in many states, the availability of rehab care is higher than private insurance, that they actually get more services and for longer periods of time. And even though they may be classified as uninsured, they're insured through another program. Now, the one thing that we also learned is now we've got to really separate these different federal programs and private insurance as we start to answer more questions about the role that insurance plays. But again, education matters, income and resource matters, and family size matters, and race ethnicity matters. It still goes back to the question of 2009. And we know in the general stroke literature that there's disparities in access to care, therapies received, and then potentially some differences in the recovery environment. And so again, we got another paper through. So now we have another building block that we can go forward. Then as we continue to dig through the literature, this issue of looking upstream has emerged. And it's emerged in a number of different ways, and I'm going to talk about how we thought about it initially and how I'm going to present it today. And it's actually a little bit different in that health services economists, folks, they think about things that are downstream, midstream, and upstream. And so when you're thinking upstream from kind of a health services perspective, you're really talking about community conditions, laws, and that sort of thing. And if you start to only look upstream, which is what we were trying to do, you're really just you're creating a disconnect in this continuum of society and person. So you're trying to separate and identify these specific issues related to society. And I'm not minimizing those. Those are real, but they I believe, and that'll be part of our discussion today, that they're part of really kind of a synergistic effect of what's happening in the community, what's happening in the individual, and that this happens over time, and that the way we measure a lot of things in stroke rehab, it's just this one point in time after the stroke event. Now, a second way of looking at it, and probably the way that a lot of folks on this call, is really looking upstream from a stroke lens, is looking to primary prevention, to looking to reduce risk. Now, that's different than looking upstream to look at the community contributions, although they're still interconnected. But there seems to be two separate literatures that are talking about this concept, but in very different ways and not in a connected fashion. Um, to make my point, I had a great doc student who we talked about looking upstream, and we weren't looking at society. She was interested in issues of allostatic load and how that might be linked to some of the severity issues related to stroke. So that's more in line with issues of looking upstream from a neurovascular standpoint, but very different than how rehab specialists look upstream, because we're using this other model that is trying to explain it through societal barriers, when ultimately it's probably both. And so when I say looking back, I'm just trying to help myself think back in time. I think about my own history a lot. My grandmothers would always ask me, Charles, how do you think you got here? And that was a very big question about a lot of different things. But when when people um, when some people become educated, it's almost like, in the view of others, all of that history before the college education is erased. And it's not. 18 years is a long time to create part of this health profile that's being influenced by stroke. And so again, we went back to the well again and started to try to think about looking upstream in terms of aphasia and really connecting it to the complete literature related to brain development and language performance. So the literature clearly says in early life, these lived experiences influence brain development and how the things that you're exposed to. Then kind of midlife, your risk factor development, which I'm going to highlight, starts well before mid, and you guys will know that it starts very early on, and then these exposures. And so when an individual has a stroke event, we're approaching them in rehab as that everybody arrived there kind of in the same way when they didn't, that it's highly variable across a number of different socio-demographic metrics. The other issue that I think is extremely important for the study of rehab and aphasia is that you can't adjust for everything and expect that to apply to real people. And if you look at most large stroke trials, people of color are going to be 8 to 10 years younger than non-Hispanic whites. And so we can adjust, and I have all these adjustments, and I'm always talking about adjustments. But the reality is, these people are coming to us at a much younger age. So you can see in this first study of those who were over the age of 55 and the non-Hispanic white, 86%. So almost all of them are over the age of 55. But look at the non-Hispanic blacks, less than 70%. So that means that there's already a big difference in these groups. When you start to look at it by age groups, it almost tells an even different story. So this is a second study, and it's not about this study because I've seen this pattern in a lot of studies that if you look on the far left and look at these age groups, about 33% are under the age of 65. When you look at non-Hispanic black men, almost 60%, and non-Hispanic black women, almost 45%. Those are very different. They're different populations. And I guess I'm not convinced that all of our statistical adjustments accounts for these issues related to age and other variables. And that might stimulate a big debate. But I do think that this matters. And I think it matters in terms of chronological and biological health because people of color are not arriving at the same way. And there's a clear literature that shows that this issue of vascular health and what might bring us to a stroke can look very different. I know that there's a lot of work on brain health, and that's probably what I'm most familiar with. But as I was going through my last edits this morning, I thought, no, 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 this is really about the point you're trying to make is about vascular health, and there's evidence that the vascular profile of people of color is created in a very different way. And aphasia is so tied into issues related to the vascular system and how people have strokes and how it impacts language zones. And so this is how I've started to think about it. And this is not true, Dr. O. I've asked him many times. This goes back to our time in Charleston of I probably learned this from him and started thinking about this. But when you start looking at the risk factors that contribute to the likelihood of having a stroke, there's some very interesting literature that shows that Black children, they're already in adolescence, they're starting to have an uptick in blood pressure. And for many of these kids, unless they're playing sports and having a sports physical, this is not going to be identified until they're in their 20s. And so that means that a lot of this damage, it's already done. It's already had its impact on vascular health. We see the same thing in type 2 diabetes, that these markers for diabetes, A1C levels, they're much higher in children of color than they are white children. So now you have blood pressure, you have issues related to diabetes, the same thing in type 1 diabetes. And this is a study from 2018, and it said that even after adjusting for all these different characteristics, that Black children were 5 times more likely to be in the highest A1C trajectory, and they were much more likely to be able to move into this uncontrolled A1C than white children. So type 1 and type 2, the impact is different, but the long-term risk for the things that we care about related to stroke are not. And then kind of the final piece is this idea of vascular stiffness. And there's a lot of literature, and it says that vascular stiffness is tied to stroke risk, and particularly stroke death, death risk. That the greater the stiffness in the vascular system, the greater likelihood a person's going to have a stroke, and greater likelihood that they're going to die from stroke. And we see in these measures very different racial difference in vascular stiffness in individuals with cardiovascular risk. So now we have elevated blood pressure, we have type 1 diabetes emerging earlier, um, issues of A1C control in type 1 earlier, and vascular stiffness. That suggests that they're not arriving at the same point. And so, whether or not you believe this concept of the weathering process, something is happening in the vascular system um, that likely has a differential impact between individuals. And so, when I think about aphasia and I go back and think about all the folks that I have seen with the condition and never thought about how they got there, but I can see that there's differences in terms of their aphasia profile, the deficit, the kinds of deficits, the issues that we decided were really related to dialect because we couldn't measure. It's not just about dialect. It's about the fact that these people are arriving in different ways, and so the impact on the language system likely differs. Now, I'm not going to try to go beyond the language system, but it's still the vascular system and it's still the post-stroke outcome. And I think that would explain some of the differences that we see in this post-stroke environment. So then if you go back to this, our thinking about language and the impact of early life, this uptick in blood pressure, um, changes in A1C, emergence of vascular stiffness, we don't know how that affects early language development, brain development, how that operates either additive or synergistically with risk factor development and profile over time, and how that brings the person to a stroke event. Because we're, as rehab folks, we're not thinking about a whole lot of what's happening before that stroke event. We tend to think forward of how can we get the best outcome, but I'm not sure that we can get the best outcome if we don't know kind of the underlying factors that are contributing. So I just have this constant question of, is there a disconnect between these different streams, whether we're looking up or down? There's problems in both areas. If you look downstream, access to quality rehab, um, insurance, bias within rehab professionals, um, lack of access to specialized care. Um, all of these things are happening all at the same time that is also impacted by a disease process that didn't just start in adulthood. And so, how do we reconcile these three areas? I want to cover one last issue that I think is part of why we're not moving forward, but to just talk about some of the findings in rehab. And so you can see the title here, No Racial Difference in Rehab. So if we think about what is happening upstream in society, or if we think about it from a disease perspective, the general conclusion is that once you get to rehab, then there isn't a whole lot of difference. And even there's some pushback in the speech world of precision rehab. Like, so everybody needs their own rehab. Well, maybe they need equitable rehab, which is they need their own rehab. But studies are showing something different, that there can be this belief, and I hope I'm not generalizing this, is that because people of color have these longer hospital stays, that maybe that's giving them some advantage or some bump. And so once you get them into rehab, as long as they get the same thing, you should get the same outcome. But we know that the longer acute care stays are tied into other areas. So in this study, they concluded there was no difference in PT, OT, speech, in terms of minutes, in terms of overall utilization. The setting didn't seem to matter, but there's an interesting thing that happens that was never discussed in this article. That you can see that this is just speech pathology. When you look at the low intensity settings for rehab, you can see that black stroke patients are always getting more. But as soon as they shift to home health or outpatient setting where you can really work with them, although they're not statistically different, you see a shift in who's getting what and the number of minutes. And I think minutes are quite tricky because those are billed minutes, not necessarily minutes engaged in rehab. So we're saying that maybe the 12 minutes in an outpatient setting doesn't matter. I would argue that that's a
Patiently
15-minute
today having
interval
so
that
late.
someone has
I'm also at a
billed
meeting
for,
and I'm
that someone has billed, and we've got to think about it in a different way. And so this is Medicare data, and they're doing the best that they can and explaining these issues, and we're doing some of the same things. So I'm not being critical of this work. I'm just saying that now we've got to take the next step. The second thing is that there were no large racial differences in transition patterns of how these people move from one setting to the next. But what is large? Is it large or is it just any? And what the literature says is that people move through pathways in very different ways. The folks that tend to stay in these in hospitals longer, it's because they're not transitioning to specialized rehab at the same rate that people who are discharged sooner. And that has been shown in a lot of different in a lot of different studies, but we haven't put all the pieces together. Um, Part of it is we haven't had the data, but it looks like the Medicare data now is going to allow us to string it all together and follow a person all the way through. Okay, again here, this is a study that shows that in adjusted and unadjusted, no differences in the people who didn't receive rehab. So again, that supports the idea that everybody's really kind of getting what they need. Um, but even in that study, at 90 days, people of color were less likely to show improvements, and actually Black people tended to have worse outcomes in these first measures. So when you start to go back to hospital stay, rehab, and then these functional outcomes, they don't necessarily map onto one another. And this is a study that I just added here at the last minute of those who are getting thrombectomy. And actually, the non-Hispanic Black people had worse outcomes at 3 months and 6 months, but somehow at 12 months, there wasn't a major difference. That doesn't necessarily align with a lot of the research that's showing this decline over time. So this is kind of when I try to put the pieces together and really what I'd like to talk about when I think about putting this together. Okay, so I'm going to erase that because in rehab we're not thinking about risk factor profile. Like the literature says it's important, but we don't measure that. Then we know that there's when a person has a stroke event, there's disparities in evidence-based care, availability of care, then the short-term stroke outcomes tend to be worse, but there's no difference in rehab. So ultimately, we should land at the same place, but we don't. We land in a place where there's worse outcomes across people of color. So this whole pathway seems to be somewhat fragmented, and the literature is not being connected across these different bodies of literature to tell the broader story. And so I kind of get to the end and I have this idea that there's probably a need for greater connectivity across all of these areas when it comes to rehab outcomes. And that's not a novel one. So here's a paper that's written in 2002, and the authors concluded if we want to make a difference, then NIH-funded studies that need to be they got to have updated objectives. And I think that's a great description of what's happening in rehab because we're trying to model all these things and control things. And within that, it seems to be that we're missing that these are real people that you can't necessarily always model. You can get some population estimates of what you believe, but it's still high variability, particularly when we start to look upstream. And so I shared a lot of thoughts. Um, I think that the real issue is that teams have to reorganize themselves with 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 many disciplines to think about stroke-related rehab outcomes in a different way instead of rehab people like me trying to draw conclusions based on an endpoint, but not really understanding the complete pathway. And I do think in the last couple of decades there have been many people who have just been on the jumped on the bandwagon for a lot of different reasons, and I don't want to get into that, but they're not fully committed to understanding this full process and this outcomes that of what the ultimate outcome is, and that people with stroke, um, that ultimate outcome can be devastating. And those that have language impairments like aphasia, it's even worse because you cannot engage in society without the ability to communicate, that you can accommodate and in many ways physical disability, but we don't have a lot of mechanisms for people with aphasia and other neurogenic communication disorders to be able to operate in a fast-paced society. So I'm going to stop right there, and I'm really interested in the group's um, thoughts because even though there's been tremendous research in the past 2 decades, I I think in some ways in the rehab arena, we're just scratching the surface, that we're just lagging behind because we want to keep doing it the way we want to. We don't want to look outside of our disciplines. We want in the speech world of aphasia, we just want speech pathologists to do all of that work, but we don't understand vascular systems the way that a neurologist would or a neurosurgeon would. And we're drawing conclusions sometimes based on a best guess or based on available evidence and not seeing the entire picture. I hope that was helpful. Those are the things I that I think about, and you can see even in my own work. I think I'm most often when I write a paper that I'm left with more questions. That I had this thought of this is what I think we need to do next, and sometimes that is what we need to do next, but oftentimes it's not, that we've figured out something that's another part of the equation, and now we've got to go in a different direction to try to pull it all together.